Hi everyone, thank you very much for joining. Um, we've just started a webinar now. We're not starting the presentation just straight away. We're waiting for a few more people to join, but our speaker Jason wants to discuss with you a little bit and just ask you a few questions if that's all right.
Hi everyone, thanks for joining, especially after probably a full day of work. Much appreciated at 7:30 lectures and speech. Much rather if there's not a lecture, to be honest. Just before I start, since you're here early, it'd be quite helpful if I could know where you're based, what grade you are, and just so that I could maybe give you a bit more pointers later on in my presentations where I should focus on, whether that's CST or ST3 applications or just generally about urology. So if you could put that in the chat before I share my full screens, that'd be quite helpful.
Mm-hmm. Can everyone see the chat?
Hi, Chase. Hi, Dina. Yes, I can see the chat.
Hi, Christo.
Would you be able to write in the chat what grade and level you are? No? Right, I think everyone's a little bit shy at the moment, so we can start with the introductions if that's right. I'll just introduce the webinar and then we can get cracking and hopefully more people will join us.
Yeah.
Is that all right?
Yeah, that's okay.
Lovely. So, hi everyone, my name is Adina. I'm the Specialty Careers Webinar Lead with Mind the Bleep. I've got my colleague, Dr. Kazu Patel, who's the article lead with Mind the Bleep. I'm really delighted to introduce Mr. Chesung, who joined us today to speak about a career in urology. So he's going to discuss about the day-to-day life in urology and touch briefly on the training pathway as well. So I'm going to hand over to Chase.
Okay, thank you, Adina. I'm just going to share my screen. Just let me know that you can see it.
Yeah, we can see it.
Perfect. So, hi everyone. I'm Chase. I'm one of the Urology ST3. I'm currently based in UCLH in London. On the side, I am an Honorary Clinical Research Fellow at King's College and Imperial College. So thank you for coming. I think you have made a very good impression already, choosing to tune into what urology could be as a career. Obviously, I'm very early on in this career, so I will only give you things that I know so far. Please don't take it as a full guide onto what urology could actually be, because it could be things that I haven't quite explored just yet. But I hope I could maybe just give you a bit pointers and a bit of a understanding into what urology could be as a junior doctor, especially when, or rather resident doctor, when you are foundation doctors, you're a core surgical trainee, or even as a specialty registrar. So this is what the talk will be about in the first part. So the second part, I thought would be to maybe share a bit of my experience in research as a non-academic trainee. Some, if not most of you, might have done more than I do or be more established, and I'm very happy with that. So this is just an anecdotal experience that I have. Just to, I hope, maybe encourage others that haven't done so to open your mind to research and find that helpful as part of your career, whatever you choose to do eventually. So let's get cracking. This is what we would like to go through today. I think I will start by telling you how I ended up doing urology and how I made that decisions, and then tell you a bit more about my experience so far in urology and how that makes me feel. Following which, I can tell you what kind of urology entails really as a specialty or as a career, as a consultant, and following which, if you're still interested and are still tuning in, how you can become a urologist if you are a trainee in the UK. And then we go to the second part where we talk about research. So this is a very interactive section, or like it to be. Please feel free to share your questions on the chat. Adina has been given the approval to stop me at any time. If not, if you think that you would like to ask me in the end, that's absolutely fine. There's no boundary to this. If there's no answers to your questions, I will let you know just as such. So apologies if I were to disappoint in advance. So to start with, I've gone through a pretty conventional pathway, I would think. So I went to Manchester Medical School for 5 years. I didn't integrate. I then graduated when COVID hit, which means that I graduated 4 months earlier, did an interim F1 job. I then applied down to South London or Kent, Surrey, Sussex area, where I did my F1 in Guy's and St Thomas's, and then I did my F2 in a mix of Guy's and St Thomas's and Maidstone and Tunbridge Wells. Following F2, I went straight into core surgical training in Northwest London. That's urologically themed. We'll come to talk about this theme training in a bit. But essentially, what I did in CT1 was 8 months of urology to start with, followed by 4 months of colorectal surgery, before I then went on to do 12 months of pure urology in Imperial College. And that ended basically 2 months ago. And now I've started my specialty training in UCLH. So essentially, through my training, through these foundations and core surgical training, I have been applying for the next step, which is not very common nowadays anymore. Which I guess I would like you to know, because I haven't done trust-grade jobs or clinical research fellows or taken years out to do, research in the form of masters and your PhD just yet. So I can't comment too much on those. But if you have any questions, feel free to ask as well at any point. So this is my journey. So I started FY1, it was COVID years. Then during my FY1 did MRCS part 1 in January and part B in July, because it was COVID and we have time on our hand. And I guess I'm sharing this part with the MRCP to let you know that at the time, I haven't fully made up my mind that I want to do surgery. And so actually in FY2, which is the earliest you could, I then did MRCP part 1 and part 2. This is quite important, I think, to share with you as part of my journey, because I wasn't someone that went through medical school thinking that I was going to do surgery, less so even urology. I, in fact, went through medical school thinking that I would do actually clinical oncology, because cancer was kind of the overall goal or overall condition that I was more interested in, where my passion is really. And as such, you can see on the right, for my research, I essentially started with a taster week in clinical oncology at Guy's, which has a bit of an overlap with global oncology, which started my research path, which I will share with you later on. Then essentially in CT2, when I was a core surgical training in urology, I also joined Imperial Prostate to do some of the research work from that point onwards. I guess this is important in the sense that I think one could keep their mind open to a certain extent, especially in the foundation years, to decide actually what you want to do, because a lot of the things you experience or you might have an impression on in medical schools could be quite different with what that job actually is like as a doctor, essentially. So keep an open mind, and you might find yourself in a different path of your training. So go straight to the point. So why urology? I think this is the 5 adjectives I would use to summarize urology, at least it is to me. And my decision to choose urology actually wasn't that aligned with this, in the sense that this is not how I got motivated to choose urology as a career. In fact, with my main passion in cancer, I chose urology kind of early on in my F2 when I have applied to both IMT and CST, and I was choosing between a urology theme job and IMT job that has oncology in it, with the thought that I might take that on and progress through to clinical oncology. The main reason I chose urology at the end was that I believe as a surgeon, you have more control or independence in treating and curing cancers. After all, 50-65% of cancers are treated and cured by surgeons. And I believe that that independence would give you the freedom eventually if you want to practice in somewhere more deprived or to improve access to cancer care overall. So that essentially was the main motivation behind my decision to choose urology over clinical oncology. And urology specifically as a surgical specialty is strong in surgical oncology. There are 5 different kinds of cancers: kidneys, prostate, bladder, testes, what's the last one I missed out? And penile. So is quite interesting, and it's a very developed field. But now that I've experienced urology, I think there is more to it, and I will go through each of these adjectives trying to convince you that there's some merits to it. So it's fun. So I don't know if you had any interactions, any experience in urology, but my general impression is urologists are fun people. We are friendly. Well, this I suppose is in the surgical realm where there are, I know, stigmas around how the surgeons could be. And I do think that that's to a certain extent is true, but urologists are definitely, I would think, the least offenders of them all. And you will find that actually we are fun because we often come across very fun stories to share, and that's from work in general and also the nature of things that we do. And lastly, probably a big cookie for the specialty, big attraction is that we're known to have a good work-life balance as surgeons. And I think this is probably on par with other, maybe equally comparative surgical specialties like ENT or plastics. And this is both in your training, so 5 to 10 years leading up to you being a consultant, and you as a consultant, I would say. Just given the nature of work being quite elective, there are emergency work, but mostly covered by juniors, and the freedom for you to purely focus on elective works as well quite early on as a consultant. So besides fun, our urology is also very progressive. So a bit of history for you. We are the first specialties that use laparoscopy. We are the first specialties that adopted robotics. And we are now also the first specialty that is using single-board robots. So I personally thought that, as someone that wasn't really surgically minded, it could be quite cool to be a robotic surgeon. After all, you are using the state-of-the-art technology, innovations to advance care. And there is a lot of benefit that could come out of it, and that benefit goes on to patient care. I think that at the end of the day is a satisfying thing to be doing, or a skill to master. And following which, I don't know if most of you have this experience, but we are also very proud of possibility to make things smaller and smaller, especially when it comes to endoscopic procedures. So obviously we are the specialties that use the most endoscopy as surgeons, because of the work that we do through, kind of transuretrally. And there are new equipments coming out that are smaller, that make things more and more less invasive and more possible, with better lasers, better wires, better scopes, anything you can think of. And it's really quite interesting when it goes through this journey, especially with your consultants as well, that would teach you how things have changed. And that sense of it being a progressive career or progressive specialty is real, and it's on almost a day-to-day basis. And lastly, we are also progressive on the kind of social front. We do have the most number of female surgeons in surgical specialties, as well as trainees ratio. I can only speak from the deanery I'm based in, and I know that in London there are more female specialty registrars than male specialty registrars. And I'm not saying this as something to be proud of, because it should by nature be equal. But unfortunately, the fact is that surgery is still male dominant in general, especially in leadership positions. But at least from urology point of view, as a female trainee, you might feel more welcome and might feel more free and have more meritocratic as a system, because we do have the highest representation of female, both as consultants and trainees. Third, I think this is something that's quite important to me. I think if you choose a career that provides you with challenges at every point of time, and I think if you are someone like me in terms of a mindset, then maybe urology is for you, in fact, because as a specialty is challenging. If you haven't done urology before, you probably would think that urology is, stents, catheters, stones, but actually it's a lot more than that. And if you think about it, you actually need to go through a lot of learning curves to be a very good urologist. So the first stigma before I joined urology that I had was that urologists are not kind of serious surgeons, a lot of endoscopic stuff, like I said, stents, and maybe robotic surgeries, but not a lot of open surgeries. But that's actually not true. There are a lot of cancer urologists or reconstructive urologists that do very serious operations in the open setting, which also means that as a urology trainee, you will have to, in your specialty training, go through the learning curve of opened, endoscopic, and robotic surgeries. Laparoscopic surgeries are on the way up for urology in general, and if you are trained, especially in big cities in the UK, you probably won't use too much of lab skills, and that's certainly not in your career as a consultant. So I think that could be quite challenging, but at the same time satisfying. So second thing about complex surgeries I briefly touch on, we are surgeons that do abdominal surgeries. We harvest bowels to do cystoplasties, and we do work very much in the pelvic area. So pelvic oncology or pelvic surgeries are part of kind of urologists within the domain of urology, really. And there are emergencies that could be quite high pressure, not quite as airway compromising maybe, but we are talking about things like obviously torsion, and other things would include prepism, penile fractures, fornias, and in fact obstructive systems, as well as obviously hemorrhage post-op. So these are emergencies that could be challenging on a kind of day-to-day basis, but at the same time quite satisfying for you as a trainee at every stage. And then lastly, given that we do deal with a lot of cancer patients, there will be mental challenge in you having to break bad news to patients and have to see very unwell or operate on very comorbid patients as well. So that's something to take note of if this is for you as a career. Next is that we are academic. Urologists as a specialty, especially in surgery, is one of the most academic specialties. So I believe, based on last year's figures, the NIHR, MRC, and Cancer Research UK, urology as a surgical specialty has acquired the most amount of money for research in general. And there are very established kind of collaboratives just within the UK institutions that will allow you to get your hands on to high quality research at different levels for you to contribute and build a career that way, which also means that a lot of the things you would end up practicing in your clinical day or clinical practice would be evidence-based, and they change very, very quickly, especially in cancer setting, uh, especially prostate cancer. And this kind of range of research opportunities truly go from exploratory science in the lab to you doing maybe clinical work, as in observational studies, could be trials, to population and screening trials like Transform. If you have ever heard of it, we have recently just achieved, or rather been awarded £45 million to run over the next 5 years. So if you think research is for you, no matter which kind of research you're interested in, there would be somewhere within the urology specialty that will fit you in, as long as you have the mind for it. And lastly, I think probably most importantly for any job is the reward that you get. And I tend to see this reward as in different domains, really. I think, this is my slice and this is done by me. And so I told you very, very early on that cancer was my main interest. And so to me, one of the most rewarding jobs is to be able to treat and cure cancers. And I would even go further to say that you could do it at a very junior level as well. So, as maybe a core trainees, you might be scrub, you might even be the main operating surgeon for radical orchidectomy in a very young male patients. And once you finish that procedure, at least I did in the first one I did, assisted by a urology consultant, you do feel that you have just treated and cured someone of testicular cancer that could be life-changing for them. And that is a good feeling to me. And other things would be, things like TURBT, which is transurethral resection of bladder tumors for non-muscle invasive bladder cancer. So this is a procedure done by every urologist, and you will be a core procedure if you are a trainee. These are procedures you can treat and probably cured, and in about 50 to 75% of those patients. So again, this goes back to the point of what gives you that satisfaction and reward when you go to work. And to me, that is what I was looking for. And secondly, with the learning curves that I described earlier as challenging, with you learning and seeing yourself doing better and better in them, comes with a level of satisfaction or gratification as well, because you would eventually find in every specialty that there are parts of the domains of parts of the work that you do that could only be done by specialists like yourself. And in urology, that is very, very clear. There are things that only a urologist would do, and you will feel that very, very early on. And I think that sometimes could be rewarding, because you then find yourself in a position where this is a specialization and you have truly developed that, and getting better at it, seeing that you are getting better at it as well. The mastery of the skills can be quite rewarding. And finally, I think as much as you would like to be, maybe one would like to be more focused on just clinical work, at the end of the day, it is work and that is life. Urologists as a whole, as a career, do okay. I think financially, at least you will have the option to be quite comfortable with your living. If you become a consultant, especially if you go beyond the NHS, wherever that could be, whatever you practice. So in private setting, there are plenty of works in different subspecializations of urology that could offer that extra support, I guess, that could make this quite rewarding as well, where you do something that you end up liking. So I think those 5 reasons, for it being fun, progressive, academic, challenging, and rewarding, would make urology quite appealing, I think, as a career, if those are what you look for in your work. So the next part is generally onto what do urologists do. I said earlier that it is more than stents, catheters, and stones, and maybe some of you don't really believe me. At least that's what your experience is in a hospital, and not when you pick up a phone to refer someone to the urology registrars or urology team in general. So on the left, there are benign urology, and these tend to be the high volume urology. So the first one being endourology, so they focus on stones. Being kind of operatively, that would mean things like cystoscopy, ureteroscopy, both rigid and flexible. That would be like PCNL, and some stone surgeons also do complex kind of open surgeries as well, but they are rarer, only in tertiary units. And second is andrology. So andrology, in other words, would be men's health, looking more into fertility as well as erectile dysfunction. Is operatively although quite limited to kind of genital area as well as kind of penile scrotal, really, and also treat testicular cancer, and can develop that as a subspecialty within andrology. Functional urology are urologies that do help with kind of essentially neuropathic bladders, any kind of things like voiding dysfunctions, and operatively this could mean a whole range of things, really. It could mean from putting sacral nerve neuromodulations into a patient, giving Botox, as well as big operations like forming a new bladder, clamp ileocystoplasty, where you basically augment the bladder by using part of your small bowels to make it bigger, and following which plus minus reimplantation of your ureter. And lastly, cystectomy, so taking out the bladder as well. Other things would include kind of artificial urinary sphincters that you can do for both male and female patients. So that all kind of falls under functional. And reconstructive urologies are more those that focus on ureter reimplantations, bladder reconstructions, as well as trauma cases within the pelvic areas. They have a bit of overlap with functional urologists in terms of what they operate on ultimately. We also have pediatric urology, which is quite interesting on its own, quite a subspecialty within urology, mostly actually done by pediatric surgeons that then develop an interest in urology, then urologists that then go into pediatric urology. But essentially what you could do with that is also things like renal transplants. You could do mitral phenoscopy or mitral formations, neobladders, posterior urethral valve ablations, and the such. So quite interesting operations, definitely very subspecialized. And the next one, gender affirmation, something newer, and this would be for patients that would like to be basically converted from a gender of birth to the opposite gender. And this is obviously very specialized, usually as a branch from reconstructive urology. And we do it now in the UK, both female to male and male to female. And that is the gender affirmation service that's kind of in the budding stage at the moment. And lastly, probably the highest volume of all, if not the same as stones, would be male urinary tract symptoms, or just generally core urology, which generally means things like TRP, resume, which is the steam ablation of the prostate, Urolith, as well as something called HOLAP, where you use laser to enucleate the prostate as well. On the cancer side, is I guess a bit clearer. It's the 5 types of cancers that I talked about within urology. But in terms of training, it tends to be broken up 2 ways. Either you could do upper tract and lower tract, or some would say pelvic oncology, where you do bladder and prostate, or kidneys on its own. Testicular cancers tends to be done by everyone, with some andrologists doing more extensive surgeries, including maybe retroperitoneal lymph node dissections. Penile cancer is highly specialized. It's done only in tertiary quaternary centers. And that will include kind of penectomy as well as formation of kind of perineal urostomy alongside it, putting in penile implants and things like that. So there is a wide range of what urologists do. It's definitely more than maybe the higher volume of what everyone sees, which is, you know, scope, stents, and catheter. So this probably is what everyone will be interested in terms of how can you get there then to be a urologist. So I guess everyone here should be quite familiar with this pathway with core surgical training, going to specialty training. There is no run-through programs within England, and there are still a few run-through programs in Scotland and Wales, which means within England, you would need to apply at least twice to get into urologist. But in Scotland and Wales, you only need to do that once. So core surgical training is increasingly themed. And what that essentially means is that within the 2 years of core surgical training, there will be one specialty that will stand out or would have, or you'll be allocated to one dominant surgical specialty. So if you are themed to that specialty, then you would do at least 12 months in that specialty in itself. I would recommend probably if you are thinking about doing urology as a career, to choose a urology theme core surgical training, simply because when you apply to ST3, there are operative experience that is based on your competency, and it's difficult for you to achieve those competency realistically under 12 months if you want to maximize your points in portfolio. So that is important. And if you were to end up doing a urology theme core surgical training and you are ranking them and you are thinking how you should prioritize them, definitely prioritize having urology in your CT1 year. Because if you were to then have to apply in your CT2, you at least have done actually those, 12 months to get the competency up. So in terms of core surgical training, I think about 1 in 5 or 6 CST job is urology theme. I applied to London, and I could only tell you a bit more about London as a deanery. So within London, when I applied, there were 110 jobs, and of which only 9 jobs were urology. So that's not quite the 15-20%. But having said that, I do know candidates that eventually manage to swap some of their rotations to get the minimum number of months they need to eventually then apply to ST3 urology. The process of core surgical training, I'll leave that more towards the end if you have any specific questions on it, because things have changed since I applied. And also, I believe Mind the Bleed has a separate talk focusing on how you could do that well in terms of your portfolio as well as your interview. So I'll leave that aside. But last I checked is about 1 to 5.25 applicant to job ratio. And obviously in this climate, there are many people that would apply to multiple training programs. So that number in itself might not be fully representative. Specialty training, which is ST3, I think to most people that want to do urology is probably where the last hurdle is, and to get it is really the golden ticket. I would say do not be fooled by the applicant to job ratio of 4 or 1 to 4, which look a lot better than maybe core surgical training, but in fact a different ball game altogether, because you will be looking at people that have committed part of their career into wanting to be a urologist. So the caliber of applicants as well as the work people have done to put in is quite different from core surgical training when things are still quite generalized and not specialized. And when it comes to specialty training for urology, if you look through the portfolio assessment, the cutoff points is actually quite high. Is I think 50 of 76 total you could get together in shortlisting for interview. And to get to 50, you pretty much have to score 4 out of 5, if not all. So 5 out of 5 in, I would say, 80% of things that you have to get done. That is excluding kind of publications, extra degrees, and prices. So pretty much everything else is almost compulsory for you to achieve before you can really look into applying it seriously. And obviously, like any other surgical specialties, you will need MRCS to enter. And my general advice for anyone that maybe have set their mind to do surgery is to get MRCS out of the way. The sooner the better. I personally would even go further to say, if you can get MRCS done before core surgical training, you will find the training a lot easier and more efficient along the way as well. At least that's my experience to it, because the last thing you want is to have to develop or get used to the new surgical environment while you develop skills and your portfolio for the next part of your training, while at the same time sit 2 exams that could be quite taxing. Part of the exams as well would have kind of general medical knowledge that you probably would know a lot better, or anatomy knowledge that you would have maybe remember better since you graduated from medical school instead of later on. And to finish specialty training in ST6 or 7, you would then have to sit 2 parts of FRCS for you to exit and complete your consultant training, so to achieve CCT. The general program is broken down within specialty training to ST3 to 5, where you are expected to achieve kind of phase 2 competencies, where technically you would then be a core urologist. And within ST6 and 7, you are then allowed to kind of choose a subspecialty, like the one I've mentioned earlier, and develop that as well. So you would then, by ST7, be completing your training with core urology as a background, as well as a specialty module of interest, which would be your subspecialty. So although fellowship is very, very common in urology, just to generally get your operative skills up and to, get different combinations of subspecializations within your practice, it is optional. So there are people that would do ST5 to ST3 to ST7 and get a substantive post right after. But this is rarer if you were to choose to do cancer work within urology, simply because of the extra learning curve of robotic surgery, where it's difficult as a trainee to maybe get to a level where you will operate independently in especially more than one cancer site. I guess alongside these conventional trainings, especially for surgery, there are alternatives routes that are becoming more and more popular. The first one is CREST. CREST is essentially a CST equivalent where you have to be very organized. You have to go through different surgical specialties. Obviously, you can theme it as you wish based on your trust grade jobs. To then get a competency to get into to be signed off. The important things to know about CREST is that there is a timer on it. You still need to do MRCS. You would need an overarching educational supervisor that would help guide you to get the signatures you need. And lastly is that you most likely would not get equal amount of training funding to go into the courses that will help you prepare for the next stage of your training, as compared to a CST equivalent. In terms of CSER is a route done after core surgical trainings, where it's essentially an alternative to specialty training, where you have to, again, be very, very organized with a timeline to achieve different competencies that you are expected to achieve as a urologist within the UK. and that usually is kind of based in a tertiary center, and you would then do different jobs rotating through them, and you would need help and support from very many consultant colleagues to get you to that point. But it is similar outcomes as a specialty trainees towards the end, especially if you practice in the UK. But do know that your certificates to enter the specialty register within the UK is different from someone that will have CCT'd, which means that there is a slight difference if you were to look to practice elsewhere that's outside of the NHS, if you were to go through the CSER pathway. So I would leave that generally like this, but if you have any questions, I'm happy to delve into it at every stage of this. Yeah. So I think I covered this mostly, but I would just so for CST, like I said, do MRCS as soon as you can. If you're interested in urology, I would definitely recommend the Bowels Urology course, which is 4 days long. And if you're a CST, you will get money compensated for that. You want to start doing some urology-based audits or QIPs. The importance here is to do urology audits or QIPs, because what I didn't do was essentially a urology-based audits. I did audits and QIPs, but they were not urology-based, which I then found myself in a position where I had to repeat, up to 4 audits or QIPs to get myself ready for ST3s. So if you can do that sooner, the better. Then the last thing, I mentioned this as well, is to prioritize the sequence of your training within CST. If you can do urology first, get them out of the way, because you want to achieve level 4 competency, which is you being independent in the operative procedures for scrotal exploration, circumcision, stents, and cystoscopy. This would be generally enough to get you to do CST and ST3 at least for an interview and clinically for work as a junior registrar. So for ST3 preparation itself, one thing to note is while your portfolio could be very good for you to be shortlisted, the moment you are shortlisted, really the playing field is even, which means your performance generally will be based on your interviews. And interview in itself is an experience that I personally think would come best if you were to practice with other registrars, especially very senior ones, as well as those that just did it, as well as consultants, because after all, you are marked by consultants. And I would tell you that for my own interview process or preparation, I have spoken to in excess of 20 consultants and registrars in combinations, just to get a feel of what everyone would like to hear in your answers in those interviews. And they are obviously very helpful interview courses as well. They do run up very quickly. If you're looking to apply, you're probably a bit late already this year, but these are the few STARS Urology, BSOT, RSMs, ST3 courses to look out for. We already talk about the portfolio cutoff points. And the last thing that a lot of people forget really is to get the clinical experience in outpatient clinic, which is a quarter of the points when it comes to ST3 application. And most of us, if you haven't done a trust grade registrar job, would have very limited experience in outpatient clinic, and you will come through very quickly in interview if you haven't got those experience. So after you have submitted your evidence for portfolios, it's time for you to go to outpatient clinics in real life to get that experience in while you prep for mock interviews for ST3. So depending on what stage you are, I think these 4 things, if you haven't already done them, could be things for you to get started at any point of time, meaning even now, to make a head start in urology. So if those are of interest, I would generally recommend these things, depending on which things appeal to you the most. And I have to give a special shout out to the BAUS, which is the British Association of Urological Surgeons, which is a very united association as a specialty, and it provides a lot of support. And the conference itself lasts for 3 days, and it's very, very eventful. You don't have to be a urologist for you to experience what the width and depth of urology is, and also the fun, because there's always social after those conferences as well. So I hope this has been a bit helpful, or at least shed some light for you in what urology means as a career, really. So that is part one of my talk before I move on very, very quickly to share my personal research experience, which I hope would maybe inspire one or two of you to maybe pick up research as something more of an interest if you are not thinking about doing an academic career. So anyone has any questions at this point of time before I talk about something else altogether?
There are no questions in the chat at the moment, but please feel free to post your questions in the chat and we'll make sure to cover them.
Okay, sounds good. So next part is about research, and I will tell you this with a very open mind. I think the main question is why are you doing research, and are you doing it mainly for your portfolio, or are you doing it generally thinking that you would want to eventually become an academic consultant, which could well do. And then the following questions is, if you then haven't gone through the research pathway or academic pathway, as in my time, an AFP, Academic Foundation Program, which I think they have now abolished altogether, to maybe being an ACF and ACL clinical scientist, associate professors, could you then do research as a meaningful part of your work, and can you truly be serious about it? True answer is I don't know, but I will share my anecdotal experience as research, which really is something that I chanced upon, and I will tell you how I did that. So just going back to my F1 year, I told you that I did a taster week, and at the time I was thinking, definitely clinical oncology. So I did that. So I took a week of my third rotation in F1. I think this was kind of April time in F1. In clinical oncologists, I simply reached out to my education supervisors that knew a clinical oncologist that was happy to have me on for a week to shadow her, basically. And then when I was shadowing her, I was in the department. I was then speaking to registrars that were doing different things with different consultants, and I had my interest mainly in kind of oncology in a global setting, especially in deprived areas. And so I was recommended to meet Professor Agarwal on the third day of my stay away, and that's how it began. We had a coffee that morning when he was on call doing a ward round. He then sent me to his office while I wait for him to finish his ward round, where I met his counterpart, Professor Sullivan. We had a chat for half an hour. Then he sent me basically an Excel spreadsheet with studies that have been done and screened for a systematic review, and say, why don't you give this a go? And send me the methods and some visuals afterwards to see how we can frame this paper. And the systematic review essentially is in the use of virtual reality in oncology setting. And really before that, I've only published a case report, and that case report was from the very first patient I saw as an F1, and that wasn't kind of what I would say a proper research. So that is how it began. So the systematic review took 8 months, 12 months. That's one thing that happens in research. Things take time. And the second thing to note, probably from my experience, is you have to take learning as within your you have to take ownership of your own learning, which means when it comes to research, there are a lot of steps that you have to kind of troubleshoot yourself and learn those skills or pick up as you go. And it's important to have someone quite senior as a mentor to get you through those steps. But essentially, as a non-academic trainee, I managed to kind of get a systematic review after over the line with a lot of help, and that essentially got published. And then following which, I was offered an Honorary Clinical Research Fellow job with the Institute of Cancer Policy in King's College London, which was essentially headed by Professor Agarwal and Professor Sullivan, for them to allow me to access the data that they have within the system at Guy's and St Thomas's while I have moved on with my work. And so with that, we have started on a couple more research And because they are also organizers of London Global Week or Global Cancer Week, I also kind of helped organize and participated in that, which I found really, really helpful and eye-opening, really, to be working with people from different realms altogether. You know, they could be physicists, they could be anthropologists, epidemiologists. They could come from all over the world in different settings to describe what cancer is. And that was one of the most satisfying kind of experience that I have in my career so far. So I kind of kept going with that kind of in the background. I was 100%. I was 100% trainee all these years, and then I realized in my core training year that because I haven't taken any year out, you know, any intercalation or any kind of master's program in research, I was actually, you know, lacking those skills that I need in research. And there are many skills you could think of, and I personally am someone that would only learn the skills if I need to use them, and if not, I would learn, I will forget. And so with these two other projects that came on, each of them in different kind of spectrum of research, one being very qualitative and the other being, you know, quantitative, that requires statistical analysis. I then took on all these courses, and the helpful thing really that I should mention here is that if you are attached to a developed research team, especially if you're a clinical research fellow, most of the teams will have some level of funding that would allow you to take on short courses that would help both with your portfolio and also for you to develop those skills to do research. So you do not necessarily have to have those skills by doing extra years like masters. You will probably develop better or more comprehensive skills, but just those few days of courses with very active application and guidance from someone more senior than you could get you to a good level where you could, you know, get to the end of your research with results that you designed to achieve. This is from my personal experience. And so I recommend in kind of in the interims of your jobs, if you're doing a trustworthy jobs, or if you're in years that you don't have to apply for the next part of your training, to get this under your belt if you're interested in research, especially if you have a project already that's ongoing. In my CT2 year, I basically took a wild shot really at a grant. So with my kind of systematic review done in VR and oncology, I then was spying or looking at this £50,000 grant that was offered by BASO, which is British Association of Surgical Oncology, and Rosaries, which is a charity which literally looks at surgical oncology and innovations. So they were basically giving out up to £50,000 for you to do original research for innovations in surgical oncology, which was basically ticking all my boxes. And I then used the systematic review as the groundwork that I've done with help from Professor Sullivan's, because he has done work with other people back in kind of 2 years before I joined them, really, in virtual reality, to then basically designed and implemented a study which helped me secure the grant. And this is truly the turning point, I would say, or where I get to a level of maybe freedom to do research as a doctor, as compared to you being given projects all the time and not having really a lot of autonomy over what you want to do. But essentially, long story short, it was looking at the use of VR to build surgical capacity in Zambia, especially in hysterectomies, radical abdominal hysterectomies for early stage cervical cancer and also postpartum hemorrhage. So you could tell that as a CT2 urologically minded trainee, that is quite a different field, which I quite enjoy. And I'll tell you why, because a lot of the things here that you want to do might not be, especially in research, might not be fully aligned with what you do clinically. And that is absolutely fine, because you will find your expertise helpful at some point within this experience as well. And it's important for you to broaden your mindset and to look beyond your specialties, to know that there are things that needs, a cross-specialty solution for. So doing this VR trial, and we're based in Zambia, essentially, I had used this as an opportunity to fly out. It's the first time for me to be in Zambia, and I was finding myself in, different cities in Zambia, and there's, outside of Lusaka as a capital, seeing district hospitals, knowing that as a country they have only got one cancer hospital was obviously
achievable and what is known, and that kind of aligns your expectations, and that was what I enjoy doing. And so this is where kind of research has led me from that path. And obviously alongside, I was always worried that this part of research really has not got a strong connection with urology, and I still am thinking about these things, because if I eventually want to maybe perhaps take some time out to do an MD or PhD, would that align with urology? But I'm keeping my mind open, and I think everyone should, because you never know where it's going to lead you and where you're going to find your urology focus, and it might well happen in the next couple of years. So alongside it, I obviously would, in my clinical work, still do urologically based research, and that's with Imperial prostate, which is a very different kind of environment altogether. You're doing kind of now clinical trials that are not the same as you doing trials with an implementation focus. But this experience taught me different things and gave me different skill sets that will allow me to build or the design that I want eventually. And from those, I got different kind of exposure, as well as different kind of academic achievements or outputs, like papers out of it, which I found very, very helpful. Obviously, it's different, because if you are not an academic trainee, you don't have, you're not like an ACF that will have 25% of their time secured away for research. You will not have the same amount of funding, although funding is only a very, very minor part of this this journey, I would say. And that a lot of these things you have to do either on your own time, or you have to take study leaves for you to achieve those. And you would need someone quite supportive as your educational supervisors to achieve those things as well. So it is something that would take a lot, especially more than your contracted hours. But if you enjoyed it, maybe the reward is worth it. So essentially now, with those two things running in parallel, it basically has taken up most of my, I would say, my own academic time, even with the study leaves that I'm allowed. But it has given me more opportunities to do the research that I want, and get that over the line to form papers and output. So research is a long process, and there are research that would take 1 or 2 years. There are research that can be turned around in 6 months. And my general advice is to be open-minded about it, because it will give you a lot more experience to your job, more than your clinical work, essentially. So this is the talk, or rather the presentation that I gave, that gave me the money that I said before was the inflection point of what research means to me. Because prior to this talk, prior to getting this money, essentially all the research that I've done was directed by someone else, and also purely UK based. But with these opportunities, and this is basically a research that was simply based on a systematic review that I've done out of the blue from a taster week. It has given me opportunities to go and to experience healthcare and even life outside of the UK. So you can see here, this is January earlier this year that we, as the Global Oncology Group and King's, did a surgical oncology workshop with the Ministry of Health in Zambia. And on the right was back in July, where we were invited over to lead the oncology symposiums as they try to decentralize their cancer services. And you're working with very interesting people. The one next to me was the chief of nurse for the whole of Zambia. They have gone through different paths and is now an oncology nurse. We have got radiology residents from MD Anderson in Texas, and we have got patient representatives on the left. That was a cancer survivor herself, 25 years plus. And here, that is the cancer program by the MD Anderson, you're seeing advocates again with the Do Good Challenge to help destigmatize hair loss in cancer. And on the right, you're seeing the surgical clinics where they see 120 patients one morning with one consultant and 2 registrars with no electronic health systems. I can tell you that that was a very interesting experience as a very junior urology registrar. At the point, I was deeply overwhelmed, and the things I see was very interesting. It does change your perspective, and that stayed on with me. And here on the left, I've been humbled as I walk through the district general hospitals to see this male circumcision clinic. That's essentially a nurse-led theater under local anesthetics, where the nurse would do up to 8 circumcisions in the morning, and that's unheard of even in an andrology list in the UK, where you would get maybe 4 top half a day. So that's how you get humbled in different cancer services. And on the right, what you see is the sites that would in a year hopefully be the 2nd cancer disease hospital in Zambia. So you do get a wide range of experience outside of clinical work, where you're not just running on the wards in theaters and being on course. And I find that really quite interesting and open up my mind anyways to what a clinical career could be. And these are the good times you get in social hours out there. On the right, that was a club in Zambia that was very interesting. And you obviously can do a bit more travel afterwards yourself when you have been flown out there. On the left is Victoria 4. You see the white rhino in the middle, and right is the African elephant just migrating through the river, just happily one day when I was there. And with the Imperial prostate team, different kind of research, clinical research, more on the day-to-day basis. As you can see on the left, we were doing something called confocal microscopy, when you try to get intraoperative surgical margins for prostates after prostatectomies. And we're very proud to be trying this product that was really just very new and just got FDA approval and approval to be trialed in the UK just a couple of months ago. And on the right was VOWS just earlier this year, where essentially we have taken up 6 out of 10 of the oral presentations section for prostate cancer, and won the best prize, the Golden Scopes as well. That's Professor Ahmed, the 3rd on the right. So it's different kind of enjoyment, and this is the leave due they did for me and the other 2 registrars and the fellow. It's all really quite social, and I think this really make work a bit less restricted to work and the stress with it, and there's some fun and a bit more kind of investment into what you do, and that is what I think research provides to the career, something more lasting and something less personal as well. So all in all, I think these are the few things that I have come down to realize that I have been very lucky with, that I think is what I would like to maybe share with you. The first one is to find a senior mentor. And I say senior because a senior mentor by definition will want different things than you. They will be looking to more coach and guide you, but expect you to have more independence and autonomy over your own learning and getting work done. But at the end of the day, in terms of output, they will be very happy to be the last author while you become the first author, which is quite important if you want to develop your research portfolio. And second, only commit to things that you can deliver. And this is very important if you want to leave a good impression, where you don't over promise things, because that would affect your trustworthiness, I think, and generally affect your longevity in a research team. So yeah, and the third thing is be accessible and keep an open mind. I think I've mentioned this many times, and I said be accessible in the form of that certain research don't have the will make you work at hours that you might not usually be working, and sometimes it's simple things like replying an email when you're on holiday so you can meet a deadline. or getting certain things done. So in preparation for your research mentors to get ready for presentations. And so be accessible really is to have that flexibility, and you have to kind of build that into your life if you want research to be part of your life as well. And the fourth thing I've mentioned is as well is to take charge of your own learning and work. No one is gonna pat your back. No one is gonna tell you or give you the money to take time out to do this course and that course. And after all, you need to bring under your belt. And it's more than just learning, it's also applying. And if you are someone like me that would only really learn and remember if you have to apply a skill, then I will pick up a research that you have no certain clue of how to achieve the end of, and try to find your way around it, whether that being qualitative, quantitative, implementational, or even biochemical or clinical informatics work. There are plenty of courses out there. And the second last is, if you were ever doubting yourself, write and submit. That is what I would recommend for everyone. And that's how I got my first oral presentations. That's how I got my first prize. That's how I got my first grant. And that's still how I'm trying to wing it now to get more to support the things I want to do. And lastly, it is a journey. It's not just about the papers you get out. It's not just about the portfolio points. In fact, those are very minimal things after you get through that. Obviously, I say with the comfort that I have now with the numbers I got, but I do seriously think that we should all enjoy the journey and take research as something that's more lasting, something more like a legacy, and something of a journey where you work with people better than yourself. And that usually means very, very good company. And this again is good times that I had while I was technically doing research on study leaves. On the left is this dance that really wouldn't stop for 3-4 hours, and on the right here is shots that we share with the consultant on the right, and plenty of registrars and even FY1s that were with us last year doing very serious research, meaning a lot of data collection between 5 to 10 p.m. After their ward day to get to where we are and present our work at about 24. So really, that is all I have. I'm sorry that I have blackbombed for, I think, probably an hour. I probably bored all of you to sleep, especially after your work day. But I'm very, very open to questions, and I want to try to keep this light.
Thanks, Chaser. That was a fantastic talk. Yeah, really enjoyed it.
Thank you.
Thank you. That was a really great talk, and you can see the passion you have for urology and research. So that was great that you shared that with us. We have a few questions in the chat. The first one is, you mentioned robotic surgery. Is robotic surgery included in urology training, or do you need to do fellowship separately?
Okay, that's a very, very good question. So from if you are trained in London, I think you can confidently be trained up to an independent level for one cancer site, and that usually means prostate. So you will, in your ST6 and 7 year, be given opportunities to operate robotically, so robotic prostatectomy, to a good level where you can do that independently as a consultant without a fellowship. But it depends on where you want to work. If you are training in somewhere less specialized or centralized, then people tend to do a fellowship to complete that, because different cancer services or robotic services have different setup. So for example, in Oxford, they do pelvic oncology and upper tract. So pelvic oncology means cystectomy and prostatectomy, which means if you're only trained in prostatectomy, you wouldn't really fit that job. So you then need a year of fellowship to do robotic cystectomy as well. But this is not the same everywhere. Well, upper tract tends to be just upper tract. So you would do robotic nephrectomy, robotic pyeloplasties, and some retroperitoneal work alongside that. So to answer your questions, I think in most of the country, this type of the training, you will need at least one fellowship to be robotically competent enough to get a consultant job.
Lovely. Thank you very much for that answer. The next question we have is, did you not consider ACF given your research experience?
No, I have considered, and in fact, I'm not sure to share with you that I did not get a ACF, even an interview. I was shortlisted, but I didn't get an interview for the ACF job. So my experience with ACF is that most of the ACF all of the ACF are attached to a professor, and most of them are already set towards a project that was designed by the professor, which means that whatever that you have set up would be helpful, but they will expect you to do things that are aligned to their line of work. So essentially, the tips to getting an ACF job really is to always have a coffee talk with the lead modules, lead ACF person before you actually go for your interview, if you don't know that already, because they will want to know what kind of person you are, what kind of experience you have, and how much interest you really have for the work that they have proposed with you. So when I applied to ST3, the ACF job was in clinical bioinformatics, so a lot of genetic stuff that I have no clue how to do at all, which wasn't really my passion, given that my focus was really in more kind of global oncology, and as well as implementational or clinical research. So I have applied, I didn't get it.
Thank you very much for sharing that with us.
No, not at all.
And the next question is, are there any specific urology workshops, online courses, or certifications I can complete? For example, basic urology skills, bladder management.
Yes. So two that came to my mind straight away, depending on the level, if you're in kind of SHO level, the emergency urology workshop is a one-day course in Cambridge that I would recommend. It will definitely make you feel more comfortable when you're doing a urology SHO job, especially when you're on call. And the second was the one I mentioned before, is the Bowles Core Urology modules. That's a 4-day course that will teach you most of what you need to know to a level of a junior registrar, and alongside which a half-day kind of mock interview kind of practice for ST3. So that is what I would recommend.
Okay, thank you. And last question we've got is, how did you go about starting your systematic review?
How did you
go about starting your systematic review?
Right. So this is an interesting process. So I was given, like I mentioned, in this spreadsheet with about 90 papers on it. So essentially what my mentor has done, or Professor Sullivan has done, was that they have found the keywords for the things they're interested in, meaning virtual reality and cancer, and they have got someone to run this search already. Usually, you can have the librarian to run the search for you, but you will need to develop your own search terms. And these search terms needs to be discussed with someone senior before you start doing your systematic review. This is very important because if your search terms miss out very important keywords, then you might miss out on a lot of the papers out there, which then will compromise the impact of your or the robustness of your study. So what you can do really at this point, either find someone like academic mentors that will have access to developing these search terms with their medical statisticians and experts, and from there learn to screen papers, develop inclusion exclusion criteria. I personally did it by reading the most recent reviews in those topics and see what the inclusion exclusion criteria were, have a general feel of these topics that is extremely new to you, and go from that. Because you don't really want it to be fully rigid to what you already knew about the topic, because then you'll be missing out. That is the good thing about not knowing too much about a topic you're going to research on, as compared to being an expert in it. So essentially, search terms, you can use actually ChatGPT now to help you. If you ask the right question, you can prompt it saying, I would like to do a systematic review in this and that for the past 20, 30 years, with papers included on PubMed, Web of Science, etc. Could you provide me with the search terms with, focus on maybe cancer, focus on virtual reality, and see where that brings you. But ultimately, the search terms should be agreed by a group of experts in those topics already before you delve into do more work.
That was interesting. I think having AI as a tool as well can help quite a bit. So it's really interesting that you can use that for systematic reviews.
Yes, and you can do that for statistical analysis as well. So if you use R or if you use data, R especially, if you copy and paste an error code when you're writing it and say you were trying to do these came out, could you help me troubleshoot it? You tend to get the answer.
That is very, very helpful to know. Thank you very much for your time and for the great presentation. I think those were all the questions that we had. Please, for everyone that's still on the call, can you please fill in the feedback form in order to receive your certificates? And if you have any questions, feel free to email us or let us know. Thank you very much again.
Thank you.